Ladies and gentlemen, good morning. I want to show you in the next few minutes that the digital is the far better way of doing ureteroscopy. So what do we require for ureteroscopy? So we require all these factors that are there on the screen, and digital produces all of them. The chip on the tip technology has clearly revolutionized vision. You can see in this picture from courtesy of Professor Traxler, the same patient, and you can see that here, that in the fiber optic ureteroscopy, you can see I got 400,000 pixels as opposed to 6 million pixels in the vision for digital. Ladies and gentlemen, the caliber is another important factor that my eminent opposition would speak about. But you could see in between the two scopes that I've labeled here, they are comparatively similar. And I've labeled here all the contemporary telescopes we have got in the market, and all of them, if you can see that, it is comparable, the caliber of these instruments. So let's go to the first case now. Because it's a video discussion, I'll show you the first video. Here we got a patient who has got lower 3 calyceal stones refractory to lithotripsy. This is using the BAUS scope, and it's 6.6 French, and this patient is virgin ureter, doesn't have any stent, and we've got the safety guide wire, and then I'm now passing the telescope. Sorry. The safety guide wire, and yeah, and now we got the telescope going into the ureter without any access sheath. We are in the kidney now, and you can now see that we are seeing the beautiful views of all the calyces, and the stones are all there in the lower calyces, the multiple stones there, and you can see that there's a cluster of stones in that area, a large stone and several following. And what's important, you can see the deflection, that you can see you can reach the lower calyx without any problem, and you can see now in the screen that the laser fiber is coming in the same place, and then it's fragmenting the stone. Even at the end of the slightly longer procedure, you can see that the vision is preserved. And you can see the glow, and then you can see all the fragments taken. And then I have left a sheath in the end just to take off the larger fragments. Very soon you can see the basket coming in and taking off the large fragments. What about ergonomics? The surgeon is also important. You can't hold this camera all the time. If you can see between the 3.2 Flex X2 and the digital versus the fiber optic, you can see that the weight of the scope is only 342 grams, and it is so light. The treatment is not just for a single stone or stones that are there, which are very well defined. Imagine this, and see this patient in here, a 74-year-old lady who's got a single kidney, and then she was admitted with urosepsis, and she's had a stent for a while. Even in this patient, you can see, first of all, just a moment to see the ergonomics, how comfortable it is. And now this patient had a sheath because I didn't want her to have high pressure in the kidney. And then you can see here, fairly large stone, and then you are fragmenting it, and fairly clear, especially if in spite of the patient having a stent for a while and all the things that go with sepsis. And in the end, the patient is treated. We know that the better vision and quicker surgery with digital. In this particular paper, you can see that the mean operative time is less, and also the amount of fragmentation is more in this patient, and the volume of stones that are treated is remarkably and statistically higher. Leave alone common examples. My opponents will say that you can't get into these small areas in the kidney with a digital telescope. In this example, you can see this patient has got a pelvic kidney, an anomalous location. It's a 3D reconstruction of this patient. And then you can see here, this is the pictures. And even in this situation, you can clearly see that that you can see the stone as well as the fragmentation that's going on, a clear vision, and even reaching these places which are so difficult to reach. Digital telescopes are statistically better in all the parameters that that I labeled before. Lastly, I want to show you the importance of digital dual-lumen ureteroscopy. These ureteroscopes are slightly larger, but then they go through the conventional 911 sheath, and then you can see that this a digital flexible ureteroscope, you can have a nice deflection, even in this larger telescope. And if you see here, you've got a dual lumen ureteroscopy in here, that you've got two channels, one to pass the laser and the other one for instrumentation. The scope is going now in. And just to concentrate on the two channels for irrigation and two channels for instrumentation, which gives you a crystal clear view, and also very important, this kind of telescopes, when you take biopsies within the kidney. As you can see, ladies and gentlemen, beautiful views of the kidney, and you get the stone in a minute, and then beautiful appearance of the stone, and then the telescope, and then the basket is passed if you want to, so that you can move the stone wherever you want, or also you can basket. The basket is going on through the other channel, and here you can see that the stone is being localized and fragmented. What about the durability? There are several papers to say that digital ureteroscopes are far durable than the flexible ureteroscope, but this is important. These are expensive instruments, and they're delicate, whether it is fiber optic or digital, and they need to be looked after carefully. So digital is ideal for visibility, caliber, deflection, channel, ergonomics, and in all these aspects. And lastly, ladies and gentlemen, you do not want to see a football, even if England have lost, in a fiber optic, but you want the digital, clear, crystal clear image. Lastly, ladies and gentlemen, it is said that imitation is the sincerest of flattery, and my opponent uses digital for his everyday practice. I rest my case. Thank you very much.
So Ben, you tell us why we should stick to fiber optic.
Sure. So can I get my slides, please? That was a low blow at the end, Shri. So yes, thank you very much, Chairman and BAUS, for inviting me to talk for the opposition. But these are the Twitter handles, so if anyone wants to comment, please feel free. I'm going to chuck you a bit of a bone at the beginning, Shri, because I think image resolution, I'll give you that. I don't think we can argue with that. But really, it certainly makes your presentations better. So that's my disclaimer from the start. Is it really just about resolution, though? And I think what's really important, what I'm hopefully going to demonstrate, is that this improved image really needs to translate to a perceivable and measurable clinical benefit. Similar paper that Shri's already talked about. Remember, this is an in vitro paper, and yes, the resolution was better. And I think on the URV is probably arguably one of the best scopes for image quality, but it's compared to a relatively old fiber scope there. I think the real difference between fiber and digital in contemporary practice is probably narrower. So I've given him that. It is a better quality image, but is it really worth it? I keep telling myself I need an Aston Martin. Unfortunately, my wife doesn't agree, and neither does my bank balance. But what I need to try and work on is addressing that cost-benefit analysis. Okay, fibre optics, I think, are perfectly reasonable for stonework. Again, I'll give him that. For upper track TCC, perhaps there's a role for digital. But for stones, I think it's perfectly good, and I don't think we can justify this luxury item. Sorry, they're a bit slower, but essentially what I'm trying to demonstrate here is that despite an inflamed kidney post-stent, the views are still perfectly satisfactory. You can access all the 8 calyces, get round the kidney, find the stone, laser it, basket it. What more do we need? So in terms of these outcomes, Shri's already talked about operative time. There is a statistical significance to this. I'd argue that, is this really clinically significant? A saving of 10 minutes in total operative time, 8 minutes. I'm not sure that we really sort of would perceive that over an all-day operating list. Interesting, that paper also showed, although it wasn't statistically significant, there was an improved stone-free rate with the fibre optics. There is a couple of papers out there now that show that manoeuvrability is better with a fibre optic camera, a fibre optic scope, and there's less access sheath use as well. Notwithstanding getting around into the lower pole, I think there's evidence to suggest that the real place where fibre optic, I think, wins is the VUJ. So my practice is, yes, I do have a digital scope, but I also have a fibre optic scope as well. And if there's any concerns with getting into the VUJ, we just swap over. The distal tip is the key determinant of that, and underlined in green, you've got the Olympus P6 and X2 from Storz, which are our scopes. The distal tip, albeit it doesn't look numerically huge, I think clinically that does translate to a perceivable benefit in the operating theatre. I don't know what's happened to the one on the left, but essentially that's a URF V2 trying to get into the same VUJ. On the right, the X2 sails straight up. This, of course, is your vision with the digital scope when you haven't got through the VUJ. We've all got to be very aware of the financial situation, and I don't think I'll be alone in central Manchester in that, you know, our departmental budgets are tightening rapidly, and these luxury items really aren't something that our management are particularly keen to purchase for us. On the bottom, hopefully, yeah, you can see that nicely. Not only the cost of these scopes almost double digital, but also the replacement and the cost per case is almost double again. When we're looking at this, this costing, Will Finch kindly gave me some slides. It's important to try and work out how many cases you get per scope. Sri has mentioned that the durability of a digital scope is better. I think there's equally arguments out there to say that it's not. So I don't think that that question is actually being answered. The new group, which Will was the lead author on, showed that there were 54 cases per breakage. Now, that is from a group of stone surgeons who are high-volume centres in the UK. I think, you know, outside that group, potentially the number of cases per breakage is going to be less, which of course means that your cost efficiency drops. When you look at the cost, it's important to think of the whole thing, the whole process the patient goes through. So the operating theatre time, the anaesthesia, so that's the anaesthetist, the ODP, the drugs, the recovery staff after, the surgeon, the theatre staff, all the capital equipment that's involved with flexible ureteroscopy. So not just thinking about the scope, but also the rigid cystoscope, the rigid ureteroscope if you use one, the C-arm, etc. The list goes on. And obviously what the trust need to do is balance that with the remuneration they receive. And similar to the robotic argument, there is no uplift for the tariff, the HRG code for digital. So it just means that that extra cost is felt by narrowing the margin. And the HRG code dropped about 2 years ago. But there is a solution, and I still think this is why we should be going for fibre optic scopes. I mentioned that the P3, probably an older generation scope in that first study I mentioned, but increasingly the number of fibres are getting better, and that translates to the vision quality. So I'll just skip through these. So the image in the middle isn't going to play, is it? Yes. So this is the X2S from Storz. Equally, I think the P6 from Olympus is a very much different scope, and this balances the improvement in vision with the cost benefit. So, in conclusion, thank you for asking me to this talk. I do use digital scopes, but this whole process has been quite eye-opening for me because it's forced me to examine practice and really work out where we take it forward. Fibre optics, I think, still is the workhorse. You've got far better access to the ureter, potentially the lower pole as well, and manoeuvring around the collecting system. It provides excellent vision for stone treatment and is a far more affordable option than a digital luxury item, which, in my opinion, should be reserved for the upper tract TCC. Thank you very much.
So, Ben and Sri, thank you for 2 fantastic presentations. Do we have are we in the financial environment to have fibre optic scopes for all? Now you need you to reach for your mobile phones. And if you go to your mobile phones, you will see on the site a choice of voting. The question we're going to ask you is digital or fibre optic. So go to your apps. And you should be able to choose the vote on the voting app whether you want to vote for digital or fibre optic. So if you've all got your phones out, we need you all to start voting now. and a bit more persuasive than Brexit or whether we're in or out. But digital just has still changing. It's close. But I think it's a slightly persuasive argument for digital. We're going to be spending more money when we get back to our hospitals. We now move on to our next debate.
Thank you, Gus. Yeah, the next debate is whether we should be using a wire or whether we should be going wireless. And our two speakers for this is Mr. Darren Smith and Mr. Jake Patterson. And Darren, you have the floor.
Excellent. Good morning, everybody. Nice presentations. Great start off. Thoroughly enjoyed seeing those. Particularly liked seeing the wires in there, more than one. So two like-minded surgeons, whether you're digital or fibre optic, a wire is your friend, and I'm counting on 2 votes in the bag to start with. Ureteroscopy. The rules. There are no rules. There are certainly no rules in this debate. These are my rules. The first one is you've got what you've got. We heard that come up very nicely yesterday morning in the Stone session, where you never give up anything as an endourologist until you're absolutely sure that you don't need it. If you run into trouble during one of these cases, and then you're absolutely sure that you need a wire but haven't got one, then you're going to be in trouble. You're going to be calling in your uroradiologist friend to put in a nephrostomy unless you can do that yourself. So rule 1, you've got what you've got. And rule 2, you can swap a wire for a tube, and then you can do that vice versa. You just call the tube whatever you like, whether it's a ureteric catheter or a flexible ureteroscope or a digital scope or whatever. I think this is a brilliant quote. I thoroughly enjoyed it when I heard it. It's worth reading out. The reason a wire is called a safety wire is because it is for safety. Well, that's brilliant. It's really precise. I heard it in Southampton in January at a teaching course by a very eminent endourologist. Maybe that's 3 votes already, but I guess Jake, you can't not vote for yourself. So that's a good quote. So I've made up another one. This one's now mine. You're hearing it in Liverpool, June 2016. The reason a wire is called a working wire is because it is for working. And we make a distinction between these 2 wires. The safety wire is for safety. I leave that one alone. The working wire is for doing all sorts of other things. So you've seen some evidence. I'm not going to show you any evidence at all. I'm just going to show a video and then a bit of opinion because there's got no evidence for the effectiveness, no randomized controlled trial for the effectiveness of a parachute. But when you're in trouble, you definitely want one. So I'm going to show you a case. This was a lady who had shockwave lithotripsy previously. She still had some pain. She'd got some residual stones. And we thought, well, that'll actually be pretty straightforward to do a flexible ureterorhinoscopy and sort it out. I've got 2 wires. I've got my blue sensor wire. I've got a cheap and cheerful PTFE wire. And this is the distal ureter. You've always got to expect the unexpected in ureteroscopy. So the distal ureter, not terribly friendly, was a bit tight. Not sure why it's doing this. But this is a digital scope. What I'm seeing is slightly behind what you're seeing. That makes talking through this quite entertaining. I'm going to have to turn around, otherwise I shall be 30 seconds behind for the whole of my talk. So we've now got a scope in the kidney. It's a little bit staccato. I removed one tiny little stone. This is now a fibre optic scope going back up, and you can see the trauma at the PUJ. That was unexpected. I'd put a digital scope up there first, and it had just made a little tear into it. So what we're doing now, I found a narrow little space. This is very weird, watching it back in flick and flick. Telescope in the kidney. There was a narrow infundibulum. This is not playing brilliantly well. Get into the calyceal diverticulum, which I wouldn't have found had it not been for the other wire. That was the working wire. It was a friend. Can laser these stones. It doesn't have much fluoroscopy now, so maybe it can work it out. It's scrolled forward, of course, for the in the interests of speed. These are little tiny fragments now. Having a wire in situ across that narrow infundibulum means that you know where you're going. The procedure's safe. It feels under control. And the laser can then be used to widen that infundibulum, which added another part to the procedure. Instead of lasering those little stones and leaving there in dust and hoping that they'd come out through a narrow channel, The channel was opened so that the scope can get back into it. So then these can be removed with a basket. You have to be versatile in the strategy here. Of course, you've got a traumatized PUJ. The other alternative would have been just to accept defeat right at the beginning and stop the case. But actually, because there was a safety wire at the beginning, it meant that it was reasonable to continue. And actually, as you can see, all of the little tiny pieces that were in this relatively inaccessible calyx have been taken out, left in the renal pelvis, not taking the scope to and fro across that challenging PUJ until the system is cleared. Just beginning to relax at the end of the case, in sort of the way that the video isn't quite beginning to relax at the end of this footage, and putting up the stent. I'm very careful here because I'm trying to put the proximal end in the calyceal diverticulum, and I'm watching it very closely on the screening, and I've chosen a nice short stent length so that there's not going to be too much nuisance in the bladder. If you're watching the UO very carefully, you'll see what I did next, which is to put the stent into the distal ureter. The problem is that the distal ureter is not at all a friendly place. That's a 24 centimetre stent, and it was perfectly judged to be sitting in the diverticulum, but not perfectly judged to be sitting in the bladder. Having a safety wire alongside meant I could put a ureteroscope back into the distal ureter, use the basket that I'd already paid for to see if I could maneuver the stent out into the bladder, grasp hold of it, but it just wouldn't come. But there's no need for friggery-pokery. I've still got the safety wire. That was the original one, and then you can just invoke Rule 2 and swap it for a tube. So a slightly unusual situation with two stents being put into the patient, one in the diverticulum but above the distal ureter that unquestionably would have led to colic afterwards, and one in the upper pole of the kidney, nicely deployed at the bottom end of the bladder. So not particularly a pretty picture at the end, but functionally perfectly acceptable, and really the two wires salvaged the case. So during ureteroscopy, it's difficult really to predict which case is going to be difficult in advance, and we certainly make them slightly more difficult as you go if you get into trouble at the beginning. It's much easier to remove a wire that you've put in when you don't need it than to put one in if suddenly you do. So the safety wire, as my excellent friend Jake would say, is for safety. You leave that alone. You can replace it for a tube, but you then can't put something else in it and take out a stone. The working wire is your friend. It's for versatility, and you can be inventive with it. During that particular case, that's what the combination of wires actually allowed to happen, which otherwise wouldn't have done. And I will just finish with why the safety wire is for safety. We can all get into various acrobatics during ureteroscopy, including slightly strange positions with our body and hands. But if you end up in trouble that you hadn't expected, then the parachute, i.e. your safety wire, is your friend. This is a nice quote that I'm borrowing from Kay Thomas when we did one of these debates before, that there are old pilots and there are bold pilots, but there aren't any old and bold pilots. And if this picture of a whole load of construction workers sitting on an iron girder building the Empire State Building without any sort of wire or a safety net makes you feel nervous, then you should use a safety wire and a working wire too. Final slide. Last year, or maybe the year before, Steve Nagata showed a picture of the balloons and said that balloons are for parties and not for ureters. And the bottom right-hand picture is a wireless. And I would contend that both balloons in the ureter and wireless are out. So vote wires. It's a vote for common sense. Thank you.
So, Mr. Patterson, is the use of wires frippery-pokery? I think that was the expression.
Mr. Chairman, thank you very much indeed, and thank you, Darren, for setting me up so spectacularly. Wireless ureteroscopy is not something that's widely done, but is there a reason for that? Is it just that we're stuck in the past? What I'm going to talk to you about is a bit about history, a bit about where we are today, and maybe what tomorrow holds, and then perhaps find out what you do, or what you might be prepared to do in your practice. I've got a picture here of the lumbering apatosaur, a giant beast of days gone by, and this reminds me of what ureteroscopes used to be like in the early days. They're giant, great big things, they cause a lot of damage, they blunder through things on their way to where they want to be. people used a lot more baskets. The laser wasn't the weapon of choice. A lot of ureters were dilated, and there was a lot of trauma. That wasn't me. So I don't disagree that historically a wire was absolutely mandated for safety to allow you to have a get-out-of-jail-free card. But this is the modern era. We have more digital technology. We're in a Wi-Fi-enabled environment. Scopes are much better. Scopes are much smaller. We're much better at using them. We're more refined, and the equipment's more refined. We use a laser far more than just pulling chunks of stone out blindly. And as Darren eloquently said, dilatation is rarely needed, and balloons are certainly just for parties. Trauma is rare. If you look at the CROWS data from 2014, the rate of ureteric injury and avulsion is much, much less than 1%. It's in fact about 0.2%. And because of that, historically the numbers were a lot higher. These things are much less frequently seen. Is a safety guide wire therefore essential? I don't think so. It can even be problematic, and some of the things I'm going to talk to you about today will follow this line. So do we practice in evidence? As Darren said, there isn't a great deal in endourology. What we have is a grade C recommendation in the latest European guidelines about placing safety wires. This is not particularly high-level evidence. It's based on history and experts' opinion as much as anything else. There's certainly no randomized controlled trial data, no meta-analysis data, lots of retrospective studies, but I will go through some of the evidence that we have to support perhaps changing what we do. A lot of these Journal of Endourology articles I'll flick through now, but sensible questions. Should the wire still be mandatory? We showed in this nice study that actually, looking back on all the cases they'd done, there was a higher rate of complications in the unit where safety guide wires were regularly used against the units where wires were routinely not used. In this paper, they looked at a cohort of around 380 upper tract procedures, and they were all attempted without a safety wire, and in about 11% of the cases, they've got themselves into a bit of difficulty, had to put a wire in, and they're able to do so in every single case. And if patients needed a stent, they got a wire in, got a stent, but 88.5% of these cases were done without a wire. Another similar sort of retrospective study, again, 92% of their ureteroscopies completed without a safety guide wire. And this study also looked at a couple of interesting factors, which I'll come on to in a moment. This slide is my little rebuttal to Darren's slide of my quote from a teaching course for junior ureteroscopists. This is the master and student role. Certainly, when one becomes the master of evil, you can do what you like. And you may not necessarily come to anything but a sticky end. But I think for most of the time, Darth Vader turned out good in the end. I think we can as well. The other thing that this is there to remind me about is about force. And some of the studies that have been looking into ureteroscopy have looked at the force required to pass the instruments. And there's certainly pretty good evidence, actually, that you need to use more force when using a guide wire to intubate the ureter to pass the scope. And we are refined endoscopists. We are endoluminal surgeons who respect the lumen in which we work. And we should not be subjecting the ureter to such high levels of force as these noted. And this is bench studies that have then been carried over into clinical studies. Certainly from a diagnostic point of view, there's lots of advocacy, and the European guidelines and the AUA guidelines for investigating upper tract TCC recommend a no-touch technique to reduce the risk of bleeding, to reduce the risk of mucosal injury. And we've all seen cases where you put the scope up into the kidney and it's full of clots already for having a wire in. And certainly at the section meeting a couple of years ago, Mike Grasso gave a very nice presentation of no-touch ureteroscopy. Safety is, of course, paramount, and none of us would ever be cavalier enough to say that you're never going to need a safety wire. So you could almost argue that wireless is a bit like tubeless. It depends how you define it. But I think safety is key. Steve Nakada has presented the fact that the ureteroscope can act as a safety wire. There's a quote that you may have already seen somewhere else today about you can swapping wires for tubes. If you've got a tube in touch-free to start with, there's no reason if you're going to then potentially traumatize the kidney, you can swap that back for a wire. And that's Mr. Smith's second rule of endoluminal endourology. I've got a video here of a case. It's a bilateral diagnostic semi-rigid ureteroscopy. The case on the image on the left is the left-hand side and done first. This is a patient who had some possible filling defects in the left ureter, previous bladder TCC. As you come in, you can see already there's an obvious tumour there and multiple small foci. The other video isn't playing, which is a bit of a shame. I did have something on there I wanted to comment on. You'll notice that there was a guide wire in the second video, which is a bit odd for a wireless presentation. But that was there because having identified abnormalities within that ureter, I was planning to biopsy it, to treat it, and I would always put a stent in after that. So I'll put in a guide wire before I perform the treatment. But that doesn't mean you can't do a safe diagnostic procedure. This video, again, isn't playing, which is slightly annoying. This is a flexible scope, again, for a diagnostic procedure being passed in a touch-free fashion. Can we get the video to work? If not, I'm sure we can see similar things later on. But successful intubation, even in difficult anatomy. So, finally, you may have seen in this month's Journal of Endourology the e-publication of this article, The Death of the Safety Guide Wire, presenting all these facts as something that we no longer need to make part of our routine practice. This hasn't even made it to print yet, but it's been e-published. You can all access it on the Journal of Endourology website. Is this something for everyone? Probably not. It's certainly not something we should be teaching our junior endoscopists to do. But when you're experienced, when you have your own exit strategy, when you have the ability to plug away until there really are no other options than putting in a guide wire, then absolutely we can certainly do that. So, wireless ureteroscopy, in the right patient, there's no reason we can't. For the right reasons, with the right kit, and you have to know your kit to be able to do this safely, in the right environment, and at the right time, there's absolutely no reason why we should follow the dogma of sticking wires into our patients for no good reason. Thank you very much.
So is the force with Mr. Patterson or is the force with Mr. Smith? We need you to get your phones out again. The question on this occasion is wire or wireless. So go to the polling app on your BAUS app, and we're wanting you to vote wire or wireless, and you should start voting now. And wires just have it by a closer margin than one might have expected. So a persuasive argument on both sides. Thank you very much.
Great, moving on. So once you've carefully and skillfully got your way up to the kidney and found your stone with or without a wire, do you want to make dust or are you going to make fragments? And to argue that for the point for fragments is Mr. Nick Rukin, and against is Mr. Calvert.
Thank you very much for inviting me today, and hopefully I'll convince you quite easily why fragmentation is the way forward. I think we both have to admit before we start this case that the solid hard stones are probably better treated by fragmentation, where the very soft stones may be dusted easily, and I think we both admit that before we start the case. But first of all, just a bit of a rebuffal. I call this the Rubik's Cube theory, and I see it many times in presentations that a 12 by 12 by 12 millimeter stone is 64 fragments at 3 millimeters by 3 millimeters. So I'd ask my colleague first, or anyone in the audience who actually remember taking out 64 fragments for a 12 millimeter stone. And this is what you may argue the problem with fragmentation and dusting compared to dusting, but I'd really like to show the evidence, and I think this is more of a theory than a true fact. Now, I've got a video to show this. Unfortunately, I think I put some music to it, so I hope it goes okay. A little bit of rock and roll, because basketing is rock and roll compared to dusting, which is more Mozart. So this is a patient who's got multiple stones in the kidney, in all the minor calyces around the kidney. And the question is here, it's very simple with a basket. You can break the stones into two and remove those stones very easily. But with your fragmentation technique, you're going to bend your scope into all these calyces, use your laser, potentially damage your scope, and cause maybe some residual fragments, which is an issue which I'll come back to again. So I think basketing and fragmentation in a case like this is very simply the treatment of choice. But let's talk about evidence. You want evidence, let me give you some evidence. EAU guidelines, 2 items are mandatory to classify stone types and to try and prevent reoccurrence of stones, and one of those is reliable stone analysis. I look forward to you telling me how you're going to analyze your stones by your dusting technique. But let's move on from that. Let's give you level 1A evidence. we'll have one evidence story. You may argue this point here. This is from EAU this year. This is a study showing that the stone-free rates are very similar between the two procedures. Maybe you've got this in your presentation, I don't know. And you may say, oh, there's 15 minutes longer to do the case, which may be significant statistically, but is it really significant for the patient or in terms of operative times? But the biggest thing about this study is look at the numbers. There's 23 patients in each arm, and it's probably nothing we can actually take forward in our clinical practice. This is a study which hopefully is going to convince you all to do fragmentation and no one vote for dusting. This study is produced by the EDGE group, which is a group of active tertiary high-volume centers in North America, and they randomized patients to dusting or basketing techniques for stones up to 2 centimeters in the renal pelvis and collecting systems, and looked at both primary and secondary outcome measures, which is stone-free rates at 4 and 6 weeks, and then the secondary outcome measures is reoccurrence at 12 months. Unfortunately, I wasn't at the AUA, but a few of my colleagues in the room very kindly tweeted these pictures, which I read whilst on holiday, and has given me the ammunition to put this debate to rest, really. This data is preliminary. This is not the 12-month follow-up data, and we'll come back to that. But what you can see quite nicely here, residual fragments. This is what's left in situ. 43% of the dusting group, which will have residual fragments. And if we look at residual fragments less than 4 millimeters being classed as stone-free, you can see the basketing group is almost purely cured, whereas your dusting group is definitely not. And you're going to have a more chance of passing those stones from the dusting group, which may be associated with some morbidity and potential long-term complications. I think we can argue that this data is not complete, and I accept that factor, and many of my colleagues in the audience have also mentioned that, but it looks like hopefully this data will finally answer the question for us. So in true British style, I think we can come back to the EU referendum, and it was a very close vote in that situation, but today I'm going to vote for the Remain campaign and give you the evidence. I'm not going to give you the rubbish with the stuck on the side of a bus. This is the evidence, simple as that. The advantages of fragmentation: you have a stone for analysis. You have improved stone-free rate shown in level 1 evidence, less residual fragments, and you have less chance of passing stones and whatever morbidity that may cause patients. Now, you're going to come back and tell me, oh, that 15 minutes operative time is very important. You get a vasectomy done on your theatre list and your managers are happy. You're going to tell me about your Rubik's Cube theory, your access sheaths, your stuck basket. But is this really important compared to stone-free for our patients? So I think the option is very straightforward in this situation. You need to vote for fragment. It's a vote for the patient. It's a vote for the right treatment. Thank you.
So, Rob, I've never seen you as Farage, but can you give the alternative view?
I will indeed. Thank you very much. Right, so fragmenting is breaking the stones into chunks and pulling it out, as opposed to dusting, which is obliterating the stone into oblivion and washing out whatever little bits of dust there may be. Now, you are right, Nick. I am going to invoke the Rubik's Cube as my first slide. So if we consider how many pieces will a 10-millimeter stone break up into and how many times you need to basket it out, I think you clearly use quite large access sheaths to get 3-millimeter fragments out. I would say that it's reasonable to reliably get a 2-millimeter fragment out. To help with our maths, I'm going to make the stone square. So a 10 by 10 square stone breaks up into 25 2 by 2 millimeter fragments, but we're in 3 dimensions. So it's 5 by 5 by 5, 125 scope passes. So what happens if you're really pushing the barrel out a little bit and you're trying to fragment a 20-millimeter stone? That's 10 by 10 by 10, 1,000 2-millimeter stone fragments. The reality is that everyone's a duster, because most of the stone that you break up actually fragments into dust. It's vaporized, or there's bits of dust. And even if you do go down this route, you're going to spend very much longer pulling it out if you don't actually dust most of the stone. So we'll watch a video, hopefully. Can it play? Okay. So this is a woman with medullary sponge kidney disease, and she's got a collection of 8-millimeter fragments in the lower pole here. And you can see the trick with this is using the laser on a really high frequency. This is at 50 hertz, And the new laser fibers that we have can take that. They can go up the 200 fibers are rated at 50 watts. This is actually quite a low energy setting. This is at 0.2 and 50, but you can push it up to 0.4, 0.5 and 50. And when you do this, the stone flies apart and there's nothing left there. You don't need an access sheath in the majority of patients. You don't, therefore, need stents in the majority of patients with these. If you're putting in big access sheaths, then you're going to need stents with it. The theatre time is less, and it's substantially less in the studies that have looked at it. You do need to laser for a little bit longer, but this time, it takes far longer to lift the fragments out than it does to do this. Now, not all lasers can go up to 50 watts. You do need a higher energy laser to go up to 50 watts, and I'm going to show you on this next slide. This is at a lower frequency, but you can still fragment reasonably well. This is actually at 15 hertz, and with this, this is actually at a higher energy, so this is at 15 watts altogether. You can still do a pretty good job at fragmenting. Now, would you stop at this moment and lift those bits out, or would you just continue on for another minute or two and the stone is all fragmented? You use less disposables. You're far less likely to need an access sheath, far less likely to need a basket, far less likely to need a stent. You've got less theatre time, so it's much cheaper for the patients. And if you do take this seriously and you really go for it with the high laser settings, we're increasingly finding that the fragmentation and the stone residual rates are equivalent with this. So less likely for access sheath, much less ureteric trauma. These access sheaths are huge. We're talking about scopes that are 7 or 8 French, and the smallest access sheaths are about 11.5 French on the outside. If you're pulling out 3mm fragments, you're probably going to need a 12-14 access sheath to do that. Much less likely to need a stent, faster surgery, less cost in theatre time and disposables, less bleeding. And really, it is the only real option for fragmentation of the larger stones, because you couldn't possibly lift out all the fragments that you'd need to for this. And the stone clearance is excellent, and that's my personal series for the larger stones, and it's been replicated in many of the case series that we're seeing published. Increasingly, people are dusters, and I know the majority of members of Nuke are dusters. Thank you very much.
So with the football as it is, I'm told we're all Welsh. Are we all dusters as well? Once again, we need your votes. So go to your phones, go to the polling app on your phones, and tell us, are we dusters or are we fragmenters? And I think if you've all got your phones out, vote now. And are we dusters or fragmenters? Aye, much more persuasive argument. We are all, the future is to dust. Thank you very much.
Excellent. I see Professor Sam McClinton is in the audience, and I don't know if you noticed, Sam, that the EDGE study people are using alpha blockers when treating ureteric stones. Perhaps you could enlighten them about the proper evidence on this subject. Good. Final debate is access sheath, yes or no, and we welcome up Mr. Alistair Rogers and Mr. Nitin Chaudhry. Thanks, Alistair.
Thanks, Chairman. I'm a consultant from Freeman, and I hope to persuade you that access sheaths really are worth the effort. Access sheaths were first introduced in the 1970s. Can we play the video, please? Let's get started. They were first introduced in the 70s, but due to some initial difficulties, they fell out of favour. The use increased again in the early 2000s with a number of developments leading to better outcomes. I work in a large tertiary stone centre with a dedicated endourology theatre. We use a luminous 120-watt laser with a dual pedal control so that you can switch seamlessly from a dusting or fragmenting setting, depending on how the stone responds in front of you. I'll illustrate the advantages of the ureteric access sheath with some clinical cases. This 65-year-old lady had a mid-ureteric and PUJ stone with multiple renal calculi, and she was pre-stented for sepsis. I routinely perform semi-rigid ureteroscopy first. It helps assess the tightness, anatomy, and feel of the ureter. It also provides some dilatation. In this case, the ureteric stones needed laser lithotripsy. I do use a safety wire. I also think the access sheath preparation is very important. Having a feel for the ureter and knowing how much pressure can be applied is all important, but difficult to teach and really comes with experience and use. This is an issue if access sheaths are only infrequently used. In this case, there was a lot of inflamed urothelium secondary to the stent, and views in the kidney were poor. This would have been more of an issue without an access sheath. However, the sheath allows a higher degree of pressurized irrigation without increasing the intrarenal pressure. The lower pressure helps reduce post-operative sepsis with sheaths. In tricky cases, I think the views are better with a sheath. With the sheath in situ, you have the option of dusting or removing stones depending on the situation. In this lady with a large number of stones, extraction of the smaller fragments was performed. The larger stones were then relocated to the upper pole and mostly dusted. However, with a large stone burden, the dust generated can impair the view, and the improved flow and irrigation that you get with an access sheath helps combat this. It was then quicker to extract some of the larger fragments rather than to try and dust it all. With so much debris, trawls with the basket ensure you don't miss a hidden large fragment, and you can also get spontaneous stone passage around the scope. There was a good result of stone clearance in this particular case. We feel that ureteric inspection is vital to assess for ureteric injury afterwards, and if stenting is required, we utilise stent on a string. And in a different patient, a small stone unexpectedly responded poorly to dusting. With an access sheath in situ, we were then able just to remove the fragments, which certainly reduced operative time. So in summary, the advantages of the access sheath are it protects the scope, it allows repeated access, it reduces operative time and costs, it reduces the intrarenal pressure, which may be important for infection and malignancy, it improves drainage and views, it reduces sepsis post-op, it allows passive debris drainage, and allows adjuncts to aid stone treatment. I value the full adaptability that the access sheath provides, where various approaches can be employed depending on how the stone in front of you responds. And when dealing with large, hard, multiple or tricky stones, then getting the setup right helps. There are now numerous size sheaths from different manufacturers. My default is a 12-14, but we have other sizes of sheaths on the shelf. We've used access sheaths in different clinical scenarios. In a lady with a Ureter covered stent for a proximal stricture in a single kidney, we use an access sheath through the stent to deal with recurrent uric acid stones. In a young lady with stones in the calyceal diverticulum, the sheath was passed into the diverticulum after a balloon to enable stone extraction and provide infundibular dilatation. We've also used an access sheath to help retrogradely change an extra anatomical stent. There are other uses of access sheaths, and the more familiar you are with them, the more you likely are to utilise them. Having performed a comprehensive review of the literature, which is poor, and if you're interested, you can read that later, really the headline findings are that there is a reduction in UTI and sepsis post-op with access sheath use. There is conflicting evidence on the ureteric injury rate compared to no access sheath ureteroscopy. Certainly pre-stenting reduces that risk. There is no increase in post-operative stricture rate that's clearly been shown. There is unlikely to be a difference in stone-free rates. The available data suggests a shorter operative time with sheaths. And using access sheaths ultimately reduces costs by doubling the number of procedures that can be performed before you need repair of your scopes and by improving theatre efficiency. Now, knowing the evidence is important, but it's also imperative that we know the results of equipment in our own hands. I keep a prospective database of all my flexible ureteroscopies, and a review of 50 of these showed that the access sheath was safe and efficacious. 85% was performed as a day case, with minimal ureteric trauma and no ureteric strictures at a year's follow-up. I accept that sometimes an access sheath is not always needed at all, and you have to deal with the patient in front of you. But generally, however, whether it's from a practical perspective, an evidence-based perspective, a safety or personal data perspective, I would say that access sheaths are worth it. And whether you recently voted with him or whether you voted with him, can I encourage you today to vote Access Sheath? Thank you.
Sorry? Yeah, excellent. Yeah, very good standard data.
All right. Well, good morning, everybody, and thank you to BAUS for inviting me to present about ureteral access sheaths. As you can guess, I'm going to be speaking against their use. So I come from a beautiful part of this United Kingdom, the White Cliffs of Dover in East Kent. But the White Cliffs of Dover also mean that we have a very high stone rate. And so we have the highest incidence of stones in the country. But that reminds me of the Channel Tunnel. And I feel that access sheaths feel to me like the Channel Tunnel being dug. You're going up somebody's ureter and digging, where you don't really need to dig. So that's how terrible it feels to me. Look at this video. There should be a sound in there, actually, but that hasn't played.
This was a nightmare at the time.
That's probably Professor Traxler saying that it was a nightmare. And I think access sheaths are, I think, a nightmare. And this is what I think of them. If you're from across the pond and you have a special relationship, you may think of this representing the access sheaths, because this looks very much like an access sheath, the NASA rocket. And while these rockets can take you to frontiers where no man has ever been before, they can also crash and burn. So let's get a bit serious now. Do you really think there are advantages of the access sheaths? Well, if I'm a duster, so I can provide fast and safe access to the ureter. I do not need repeatable access most of the time. I've never used high-pressure irrigation because I think it's easy to break stones without high-pressure irrigation, and therefore reduction in intrarenal pressure is not an issue for me. If you talk about protecting your ureteroscope, well, I think we just need to train ourselves and our staff better, and we can look after our scopes very well. We have a very low damage rate to our ureteroscopes. Now, as you can tell, I'm a bit of a dinosaur, and I've done ureteroscopies way back from the mid-90s. And at that time, we used to use a 14 French Wolf ureteroscope. Now, then we made progress, and we've come down to 6.5 French and 7 French scopes. Now, why on earth would we want to push a 14 French access sheath up somebody's ureter? I just think that it's not progress. I think it's going backwards. So let's come back to some serious stuff. Yes, the paper by Professor Traxler from JUROL 2013, it looked at the ureteral wall injuries associated with the access sheaths, and that was consecutive 359 patients in which there was an incidence of 13% severe injuries with a 46.5% overall complication rate. I do believe, and I'm sure you'll agree with me, that the ureter is a sacred structure and must be treated with the greatest amount of respect. The next thing is blood flow in the ureteric wall. And studies in the porcine model have shown that the ureteral blood flow decreases by 68 to 88%, depending on what size access sheath you use. And there is no necrosis, but ureteral wall thickening and collagen deposition is seen. Now, there is no long-term evidence yet available, but I personally feel that when you have put in an access sheath for an hour into somebody's ureter, you will find that there'll be ischemia, which then induces a slow fibrosis over many years. So I would say, not my ureter, and therefore not my patients. The Crowe's study from the Endo Society has also shown that access sheaths are used more in the US. Stone-free rates are no better with the access sheath, and infectious complications are reduced, and that I accept and agree. But Burke et al. In the World Journal has also shown that stone-free rates are no better. But look at the bottom line there, 17 perforations in 1494 patients. I mean, I've done over 1,500 ureteroscopies, but I've had one perforation, and hopefully it'll be something like that. So I think that access sheaths cause trauma to the ureter, which is really not needed. We have a local study as well, Somani et al. From Southampton, and that is a small study, but it's a well-designed study, and it shows that there is no difference in stone-free rates, no difference in complications, no difference in the average number of procedures, operating time, whether patients have been stented before or not. So let's look at a video of a stuck access sheath. That's the stuck access sheath in there, and somebody's been trying very hard to do something about it. And then you get a readout. I don't think any endourological surgeon likes seeing readouts. I don't think it's a pleasant sight at all. Eventually, they managed to pull it out. But at what cost and what trauma, how much trauma to somebody's ureter? I do believe that, again, the ureter is a sacred structure that we must not traumatize. And as a consultant, you've got to look after somebody's ureter for, many, many years. Look at the other effects and aspects of these sheaths. They cost between 70 and 90 pounds a sheath. And I think, if you look at the number of sheaths used in the country, are we systematically bankrupting the NHS? We can also see that placement sometimes fails anyway. And the conservative study, up to 16% placements will fail. You also have problems with strictures, kinking of the ureter, anatomy problems, J-hooking, and old age and male sex are factors. What I do personally is I use, for every ureteroscopy, I use one Terumo wire, one open-ended ureteric catheter, one laser fiber, and I irrigate without pressure. And my personal series over the last 12-month period, which was presented yesterday, for 237 ureteroscopies, show that we have a very low rate of complications and sepsis. So to recap, do you really want somebody shooting off rockets up your ureter? Do you really want somebody burrowing tunnels up your ureter? Well, personally, I think not. Thanks, but no thanks. Thank you very much.
And so quickly moving to the vote for our final vote of the day. Do you regard the ureter as sacred, and do you think it should be, or do you think it should be accessed with a sheath? Vote access sheath, yes or no. Start voting now. And tighter than Brexit and Remain. 50-50, we're half. So we are dusters. We may be access sheath users. We're not sure about whether we use wires or not. And we're certainly not going to spend all our money straight away on fiber optic scopes, but we're thinking about it. 8 fantastic presentations. Thank you very, very much. And thanks for all keeping to time.